Hello, everyone. Welcome to the Novo Nordisk Network for Healthy Populations seminar series. Normally, you would hear Dr. Lorraine Lipscombe introduce you to our seminar series, but because she's presenting today, I have the pleasure of introducing her and her talk today. But before we get to that, I'd like to start off by acknowledging the land on which the region of Peel operates, and it's part of the treaty lands and the territory of the Mississaugas of the Credit. For thousands of years, Indigenous peoples inhabited and cared for this land. In particular, we acknowledge the territory of the Anishinaabe, Huron-Wendat, Haudenosaunee, and Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississauga of the Credit. We are grateful to have the opportunity to work on this land and by doing so, give our respect to its first inhabitants. We are all treaty people. Many of us have come here as settlers, immigrants, newcomers in this generation or generations past. We would like to also acknowledge those of us who came here forcibly, particularly as a result of the transatlantic slave trade, and pay tribute to the ancestors of African origin and descent. So, welcome everyone, and thank you for attending today's Network for Healthy Populations seminar. Dr. Lorraine Lipscombe will be speaking to us today, and her presentation is titled Avoiding Diabetes After Pregnancy Together with Moms, and it's short form for ADAPT-M, Bridging Care from the 3rd to the 4th trimester. Before I introduce Dr. Lorraine Lipscombe, I'd like to quickly review some housekeeping items. We appreciate our audience muting themselves during today's presentation. There will be an opportunity for questions at the end of today's session, and we will be inviting questions both through the chat box or by using the raise hand function. If you have any questions during the event that you would like to the speakers, Dr. Lipscombe, to address at the end of today's session, please enter them in the chat box. Lastly, please note, similar to all of our sessions, today's session will be recorded, and we will make sure the recording is available on the network's website. Now, I'd like to introduce our speaker for today. Dr. Lorraine Lipscombe is a professor in the Department of Medicine and Dalla School of Public Health at the University of Toronto, as well as a clinician scientist and endocrinologist at Women's College Hospital. Dr. Lipscombe leads an internationally recognized research program in diabetes epidemiology and health services, with particular focus on health services for the management and prevention of diabetes in women. Dr. Lipscombe is also the executive director of the network of the University of Toronto's Novo Nordisk Network for Healthy Populations, which is a cross-disciplinary research network that aims to address the burden of diabetes and other chronic diseases with a focus particularly on the region of Peel. Dr. Lipscombe received her MD medical degree from McGill University, followed by training in internal medicine and endocrinology and a master's in clinical epidemiology at the University of Toronto. She has published over 150 peer-reviewed articles and has held numerous grants and career awards from CIHR and Diabetes Canada, where she currently serves on the board of directors. Without further ado, I'd like to pass the mic to Dr. Lorraine Lipscombe, who will take it away.
Thanks so much, Gazelle, for introducing me today. And it's such a pleasure to be on the other side today. Normally, I'm so privileged to be able to host this seminar series and to have such a wonderful array of speakers who join us once a month to tell us about the research. And I thought, it was probably a good time for me now to take that spot and tell you a little bit about some of the research that I do, specifically related to prevention of diabetes in women who've had gestational diabetes. And we are focused on 3 regions of Ontario for this work, and one of them is Mississauga and region of Peel. So I thought it would also be of interest to this group to understand what we're proposing for the region. All right. So I'm just going to start by telling you what I'm hoping to cover in the next, maybe 45 minutes or so. One is, I'll just give a brief overview of, why we're doing this work by, talking about the evidence for diabetes risk and prevention after gestational diabetes. Then I'm going to take some time to discuss some preliminary results that we have from a novel health coaching program called Adapt-M, specifically for postpartum women with gestational diabetes. And then I'll talk to you about our next steps, how we're trying to come up with strategies to integrate postpartum diabetes prevention services within healthcare settings. So why are we interested in gestational diabetes or gestational diabetes mellitus GDM? Well, I think most people here are aware that while it is a temporary condition that affects about maybe 10% of pregnancies now, and it generally comes up in the middle of pregnancy between 24 and 28 weeks. All women are screened for it. About 10% get diagnosed with the condition, and it is treated during the pregnancy to help optimize the health of the baby and mom's delivery. It goes away in about 70% of women. 30% will have some persistent glucose intolerance after they deliver, but even if it goes away, it does carry with it an up to 50% lifetime risk of type 2 diabetes in the mothers. So, and why is that? Well, because gestational diabetes is thought to be an early marker of future diabetes risk. So it's identifying the excess stress on the body from pregnancy is identifying women who have this vulnerability to type 2 diabetes. And so it is a window of opportunity for us to intervene when people are engaged with the healthcare system. They are focused on improving the health of their babies and that of the families, so and for themselves. And so it is an opportunity for us to intervene. And we know that it actually can progress early. 20 to 50% of women with type 2 diabetes, with GDM, actually progress to type 2 diabetes within 10 years of the pregnancy. And in fact, even after delivery, even if the actual blood sugar results go back to normal, there is some evidence of underlying ongoing metabolic abnormalities. So there is a real opportunity to intervene right away. We also know that type 2 diabetes can at least be partly prevented with behavior modification to promote healthy nutrition and physical activity. So this, again, is an opportunity for us to help make sure that women have the supports that they need to help them stay healthy, especially during this demanding time in their life. All right. So this is just a very busy slide just to show you there's been lots of evidence showing that there's an increased risk of type 2 diabetes after gestational diabetes. This is a meta-analysis that summarizes a bunch of studies that looked at whether the risk is higher or is higher than the average for if they have gestational diabetes. And they then summarized the results, and when they combined all these results, they estimated that it's about almost a 10-fold risk, 9.5-fold higher risk of getting type 2 diabetes compared if a woman has gestational diabetes compared to if she doesn't. And so, and in the first 5 years after delivery, that risk is about 17-fold. So it actually occurs early. So highest risk is in the first 5 years. So we need to intervene early. So the guidelines to manage gestational diabetes for Canada actually recognize that. And so these are the two guidelines related to postpartum care for women who've had gestational diabetes put forth by Diabetes Canada in 2018. And there are two guidelines that are important to remember. One is that because of that persistence of glucose intolerance, all women do need to be screened for dysglycemia some point between 6 weeks and 6 months postpartum, ideally. Secondly, regardless of what their tests showed after delivery, all women should be given some sort of counseling for healthy behavior interventions to reduce their risk of future type 2 diabetes, as well as potentially reducing repeat gestational diabetes if they get pregnant again. So help improve things so that they're at a better place for their next pregnancy. And so, what are the benefits of health behavior interventions? I did allude to the fact that, by providing people with proper support for health behavior modification, we can help them reduce diabetes. Well, what's the evidence? So this was a landmark trial from 2002. Many of you probably know it. It's called the Diabetes Prevention Program out of the United States, where over 3,000 adults who had pre-diabetes and they were older were actually randomly given an intensive lifestyle program for about 3 years. They were given a pill, metformin, or they were given just usual care, which we call placebo. And what you can see here is these lines represent time along the bottom line, and on the top line represents the cumulative incidence of diabetes in people who had pre-diabetes. And you can see that people who didn't receive anything specific, they had this ongoing increase of about 40% incidence of diabetes by 4 years. Whereas if they got a lifestyle modification, so intensive physical activity and diet support, that risk went down to less than 20% by 4 years, with metformin being in between. And so lifestyle modification was shown to be the most effective way at helping people who are identified at high risk of diabetes prevent progression to diabetes, with an estimated reduction of about 60% over about 3 to 4 years. And what about after gestational diabetes? So we also have evidence that if you provide tailored behavioral interventions to women who've just had a baby and had gestational diabetes within those first 3 years after delivery, you can also reduce their risk of diabetes. This is a meta-analysis of a bunch of studies that looked at that. And what I'll show you is that if you look at the individual studies, this line means no difference. There actually didn't seem to be a significant difference with the exception of 2 studies. But when you combine all the data together, they did show that there's about a 43% risk of a reduction of type 2 diabetes. So these types of programs, if they're delivered properly, they actually work at helping prevent diabetes in women who've had GDM. And in fact, this was a more recent study that incorporated some better methods and more recent data. And the message is the same, even though the impact might be more modest, but still a significant 24% reduction in type 2 diabetes. So we know that if we can provide women with structured programs that help them optimize their diet and physical activity after they deliver within those first 3 years, that can actually have a benefit on their health. And so what do we know about these programs? Well, most of the programs, I've just listed what some of the components of these programs, most of them last about 6 to 12 months in duration. So a woman has to commit 6 to 12 months of her time to enroll in these programs. They start between 1 and 3 years after delivery. All of them provide evidence-based diet and physical activity education. Importantly, it's not just a one-time appointment. They don't just see a dietitian or see a nurse or a doctor and told, this is what you need to do, go on and do it. They actually are given frequent follow-up. And so that's really important as well to keep them going, right? Some of the studies used in-person appointments, some of them used virtual appointments, some of them used one-to-one counseling, some of them used group counseling. So pretty much a lot of variability in how they were delivered, but most of them had those first 4 components. And what's the evidence of what works and what doesn't? So the greatest benefits from these studies were seen in programs that used an individualized or customized approach. So they really worked with the woman to customize their diet and physical activity counseling to their needs, their education, their cultures, etc. They used something called goal setting, which we'll talk about more in a moment, but making sure that instead of just telling a woman you need to exercise 150 minutes per week, they actually help them come up with personalized goals to help them get there. The ones with longer duration, so at least 6 months, if not longer, seem to work better. And the ones that started in the first postpartum year seem to work best as well. You would think that that wouldn't be the case because women are so busy during that time. But in fact, I think the evidence suggests otherwise. And my speculation about that is because this is a time where women are just, starting their new life with their new baby. And so it is a time to capitalize on that change. And women might be more engaged to develop new habits and new behavior support. Some limitations from the evidence to date, though, is when you look at the individual studies, the effectiveness was very limited. And that's due to a number of reasons. One is because follow-up tended to be short, so they weren't able to look longer term if diabetes was prevented. But more importantly, the big issue has to do with delivery of these programs. So it's not so much that the programs themselves weren't good and effective and based on evidence, but it was that they had a really hard time getting women to enroll in the programs. They had low referrals to the programs. And once they were enrolled, there was variable adherence or sticking with the program and retention. And oftentimes, once the studies were finished, there was no kind of effort to implement these programs into the real world, into practice. So that's another big limitation. And so my work has really tried to take all this evidence, and as we've been doing this work, incorporating this new evidence has come forward to try and create a sustainable model of care that we could actually, that will be effective, but we can implement into the healthcare system. And so to do that, we need to understand what the problem is. What are the barriers to postpartum care in this population? Well, there are barriers both at the health system and provider level, as well as at the patient level. So at the health system level, we know that these women get really intense care from their prenatal diabetes team and their OB team while they're pregnant. They get frequent follow-up, they're monitoring their blood sugars, they modify their diet is reviewed. They get lots of diabetes care. But once they deliver, they are actually discharged from the diabetes clinic. They're discharged from the OB, and there's a variable transition in care from that prenatal to postpartum period. So many of these women are basically told, go see your family doctor to get screened for diabetes and get the counseling for ongoing diabetes prevention. And we know this is a busy time for women. We know the healthcare system is very fragmented. There may not always be communication between the prenatal and postpartum teams. So for all of these reasons, the transition doesn't happen very well. And even if the women did get to the family doctor and the family doctor has a diabetes team that they can refer them to, or they talk to them themselves, they often have limited training and time for proper effective diabetes prevention strategies. And so we need to figure out how best to support primary care so that they can deliver effective diabetes prevention. And there's also this uncertain acceptance of responsibility, particularly when it comes to ongoing diabetes follow-up. Is it the prenatal team that should still be following? Is it the primary care? Is there another team that should be following these patients afterwards? And then variable access to diabetes services. Not everybody has access to, diabetes resources, let alone primary care in these days. From patients' perspective, we know this is a really busy time for people. I don't need to tell people this. Anybody who's had a baby knows this is a really demanding time that's low on energy, motivation, and time. We've also shown that many women with gestational diabetes don't actually perceive themselves at high risk. They don't actually get the message that this is a risk condition for future diabetes. And even if they do see the risk, they see it happening maybe 20, 30 years later, not in the next 5 to 10 years. And when they do get their blood test done and it's normal, they may get this false sense of reassurance that this is no longer a problem for them. And then, of course, some women don't have really good skills with how to make the right behavior changes. They may not have the right social or family support to help them take care of themselves. And there are many obviously there are childcare demands, very real responsibilities that take precedence with the motherhood role competing for self-care. So self-care always comes last in this situation. So our role is to really help women incorporate self-care with this demanding motherhood role and these real challenges that a lot of women face taking care of themselves. So right now, it's really a missed opportunity for diabetes prevention that we need to address. This is just a study that my student did last year where we looked at a group of women who've had gestational diabetes, about 329 women, and we asked them, we had this validated survey for how ready they were to make behavior changes at different times after delivery. We surveyed them at 3 to 11 months postpartum and then again at 12 to 24 months. And we asked them separately for physical activity and diet. And all I want to show you here is the light blue is the first postpartum year and the dark blue is the second postpartum year. My hypothesis was that women would be more ready to make changes when the demands of motherhood would go down by the second postpartum year. But we were surprised that that wasn't the case. They had over 50% of women were in a pre-action stage of change for physical activity and over 80% for diet. And that didn't change by the second postpartum year. So in other words, over 50% of women were not ready to make changes, and that didn't change by the second year. So not only does it not make any difference to wait to the second year, because it doesn't change, they're not more ready, but we actually need to incorporate strategies to move them into a more motivated, readier state of action, because right now they're telling us that this is not a priority for them. So early intervention is crucial, and our strategies need to get women motivated and help them make those changes even when they don't feel ready. This is a complex figure, but I really like it because it was a review that actually specifically looked at some of the reasons why it is so difficult to engage this population in diabetes prevention strategies after gestational diabetes. And the big themes that came out were that the role of motherhood competes with self-care. I already mentioned that, but the three descriptive themes that came out that compete with self-care around priorities for mother is one, their identity as a mother and wife influences their behavior for self-care versus other behaviors. Two is their priorities of childcare versus self-care influences their behavior. And three, feelings of guilt influence their behavior. They feel guilty when they take care of themselves, when they know they've got a baby to take care of and a family to take care of. So what this study proposed, what this paper proposed is we don't just say, oh, well, you shouldn't feel guilty, you should not prioritize your family, but rather we take those themes that we know are very strong in the role of a mother, and we actually incorporate them into the type of support we provide women. So an example of that is when we look at for diet and physical activity and program engagement, those are the three places where there's difficulty engaging these women. We see the barriers for all three are caring for children. So how do we fix that? Well, we say for diet, you need to be healthy in order to be able to care for your children. So it's not just about healthy for a selfish reason, be able to care for your children. For physical activity, you need to demonstrate. You need to lead by example, be a role model to your children for healthy behavior. So if you're physically active, your children are more likely to be physically active. And then for barriers around being able to attend programs, make sure that our interventions are child-friendly and accommodate the very real needs of childcare. This is a wonderful schematic that was put together by one of our colleagues, Dr. Kara Nuremberg, out of Calgary, who's an expert in prenatal and postpartum care for women, particularly women who have high-risk pregnancies. And she developed this model of a gender transformative approach to providing support for women who are pregnant and postpartum. And she created these increasing levels that we have to consider when we're creating programs for this population. And she used the example of women with high blood pressure in pregnancy. So at the very micro level, you use individualized goals. And then you go up above with gender sensitive interventions where you incorporate family and social supports, gender specific interventions, making sure that our healthcare system and healthcare professionals specify female specific interventions, and then gender transformative interventions where we go all the way up to community programs and public policies like parental leave, nutritional supports and food banks, infrastructure for physical activity, subsidized childcare, things like that. So with all of that background, let me tell you about the program that we developed and some of the evidence behind it. So when we sought on this journey, we had three priorities to when we were developing this program. One is we needed a program that this population can access and stick with. We know this is a demanding time. They need to be able to access it and they need to be able to stay in the program. We need it to be evidence-based, needs to show evidence of use evidence-based strategies to prevent diabetes. And really importantly, we wanted to make sure that this program could then be translated into the healthcare system, could be something sustainable, because we felt strongly that everybody should have access to this program and that this would be, and that diabetes prevention is a health system priority and should be delivered within the system as opposed to outside of it. And so we started out by doing an environmental scan and looking, are there any programs out there that we can borrow from? And the one that we found was a cardiac rehab program at my hospital, Women's College Hospital, that was specifically designed for women. It was a 6-month exercise program for women at high risk of cardiovascular disease. But the important component of this, and this was back before COVID, was that most of it was delivered via telephone, where women could do the exercise at home, and they were given coaching to help them find opportunities to be physically active in their own homes and communities rather than bring them to a gym. It was personalized, regular telephone support, and they were able to show really high adherence in these older populations. So what we did as a first step is for a proof of principle is we enrolled 12 postpartum women with GDM in this existing program. And to our surprise, women loved the program. They stuck with it for 6 months. There was high adherence, high acceptance. They really liked it. And we're actually able to show significant improvements in fitness after 3 months that were maintained at 6 months in this small group of women. So we decided to take this model and actually see where we could actually find a home for this model for women with GDM. And so we actually went to diabetes education centers in the community around in Toronto to see if anybody would be interested in, with the proper training, in having their certified diabetes educators help us design and deliver a program like this specifically for new mothers. And so that's what we did. We co-designed this program with patients, providers, experts, called Avoiding Diabetes After Pregnancy Together with Moms, or ADAPT-M, a 6-month program where women were given were matched with a certified diabetes educator coach for 6 months, mostly delivered by telephone, customized evidence-based diet and physical activity education, regular scheduled phone follow-up, and using behavior change techniques such as goal setting and SMART goals. And so the program had, as I mentioned, customized education with web-based resources for physical activity, using working women up to 150 minutes per week of physical activity and strength training, incorporating the postpartum state, looking for opportunities in the community for mom and baby programs, stroller walking groups, things like that. Healthy eating guidelines with low GI diet. We did not focus on weight loss for many reasons, not the least of which a lot of these women are breastfeeding, which we wanted to encourage. So we don't want them to start restricting food. And we provided coaching. So what that involves is really individualized goal setting for behavior change, motivational interviewing, navigation of resources in the community and in healthcare, and emotional support. And they were given 1 in-person visit and 12 phone calls over 6 months. So we started out, as I mentioned, between 2012 and 2014. We've been going on for a while with this, with funding from CIHR, Diabetes Canada, and the Lawson Foundation. With the pre-pilot, as I mentioned, we designed the program, we trained coaches, we recruited our diabetes education centers. We then did a pilot phase where we looked at the feasibility data. We didn't look at the outcome data yet. We modified the program, and then we continued the trial with an RCT up until 2022. The pandemic, of course, as you know, hit during this time, which really affected our numbers, unfortunately. And we've just almost, I know it's been 2 years, but it took us a long time to collect all the data. We had diet data, we had physical activity data, we had implementation data. And so it's taken us a long time to clean and analyze all of these data, and we are going to be publishing the data very soon. So I will not show you the effectiveness data today because it's still unpublished, but I will show you some of our implementation metrics because I think that they'll be interesting to this audience around like how did it actually get implemented and what were some of those things. So just to remind people, just to tell people how we designed the study. At the time, we actually divided women up into 4 different groups. Using this 2x2 factorial. Don't worry about the name, but basically women either got a 6-month health coaching program where they got coaching both on physical activity and diet, or they only got coaching on physical activity with standard diet counseling, only coaching on diet with standard physical activity counseling, or just one standard care counseling visit with a diabetes educator around diabetes prevention. So the other 3 of the groups got the 6-month program just with different education. And then only one group got no 6-month follow-up. This is a very busy slide. Basically, women were all recruited in pregnancy from, we think we had 4 hospitals involved where we introduced the study while they were pregnant in a diabetes clinic. They were recruited. Then we invited them postpartum. They didn't do anything during pregnancy. They just were told we're going to contact you again postpartum. And then postpartum, we brought them in for a baseline visit where we would do all the assessment and then randomize them to one of the 4 arms. Everybody got their in-person visit, but then the ongoing follow-up depended on which arm they were in. And then they finished at the end of 24 weeks or 6 months. Obviously, the pandemic hit. These were all the outcomes we looked at. I'm not going to list them all. You can read them there. But basically, when the pandemic hit, we were no longer allowed to bring women in person to assess them. And women were no longer going to the clinic in person. So we had to change a lot of our approaches, and we had to drop a lot of these outcomes that couldn't be done in person. Okay, so I'm going to tell you a little bit about what we found so far. So just to give you a bit of a framework, this was considered both an implementation and effectiveness trial. So we wanted to look at the implementation metrics because we want to be able to translate this into the real world after. And then we wanted to look at its effectiveness on reducing diabetes risk factors. So for implementation metrics, we looked at reach, how many people were we able to enroll from the target population. We wanted to look at adoption, make sure this is being properly adopted by the people who need to deliver the program. Implementation, make sure that we're actually delivering the program properly. Maintenance, we're now looking at long-term maintenance. And then effectiveness, we looked at different things like population health, equity, experience, and costs. Okay, so these are our numbers. Okay. So as I told you, we had a phase 1, which was the pilot phase, and phase 2 was the full phase. And the total number of women we enrolled was 549, which was 557. That's the wrong percentage. It was actually more. We met our target for the pregnancy enrollment, but we had a significant drop off by the time we tried to bring them back postpartum. So only 60% came back postpartum. And so we didn't reach our target ultimately there. And then about 70% completed the program, which is actually pretty good compared to many of the studies we looked at. Many of these women, as I mentioned, in other programs didn't stick with the programs, whereas we were able to show at least almost 70% who stuck with the program. Clearly, more women stayed postpartum and stuck with the program in the pre-pandemic phase versus the post-pandemic. During the pandemic, we lost more women, but overall we weren't too bad. But unfortunately, because we couldn't bring women in to weigh them, we didn't get, when we wanted to look at weight as one of our risk factors, we only got 64% of weight. So overall, we had 225 women who completed the program, but we have data on 326. This is, again, just a snapshot of what these women looked like across the 4 arms. Women were about 35 years, 36 years old. Very interestingly, the nature of Toronto, or the Toronto community that we targeted is there's a high ethnic minority population in these clinics. And so as you can see here, we had anywhere from 2/3 to up to 70, almost 75% who were non-Caucasian, and many of them were new immigrants. A fair number, had lower income. Many of them were highly educated. A lot of them had a family history of diabetes. For over 50%, this was their second or more pregnancy. And with that in mind, about 1/5 or so had diabetes in a previous GDM in a previous pregnancy. We were able to bring women in around 17 to 20 weeks postpartum. A lot of them were breastfeeding, which was great. And here are some of the other metrics that at the baseline. Okay, so what did it look like when we implemented? Well, we were really happy that the 75%, sorry, how shall I say this? So that 9 out of 12 mean calls were completed per participant. So this told us that the majority of women were able to complete at least 75% of the calls that we had recommended for this program. That tells us that our approach to having scheduled phone calls was a really good strategy to ensure that women were able to actually engage on a regular basis with their coach. So high participation in the program calls. The calls per participant in minutes were about 15 to 20 minutes, so not very long. And the program lasted about 20 to 23 weeks. And just for people who are thinking they would like to potentially implement this program in their own diabetes education center, we estimated very liberally about 8 to 10 hours of committed time from a certified diabetes educator per participant over 6 months. So it was considered to be a low-cost, highly feasible program that could be delivered within these diabetes education centers. This is just to show you the percent of call completion by the different groups that people were in. And I'll just orient you to greater than 75% of the calls completed. The majority of women, at least in the physical activity or diet alone group, almost 50%, completed 75% of the calls, with the rest, somewhere in here. What's interesting to note is that when we tried to combine 2 goals, physical activity and diet, the calls dropped off. And so we worry a little bit. We're gonna look at this in more detail. And we also looked at some interview data with the women that it was a bit overwhelming for women when we asked them to try and come to address 2 goals at the same time. So moving forward, our recommendation is you do provide physical activity and diet, but that the women can select which goal they want to focus on any given week. In terms of what women talked about during the calls, we reviewed the health coaching notes, and we're happy to say across all the groups that almost 100% did do goal setting and motivational interviewing with respect to focused on behavior change, with the second most common topic of conversation, about 50% of women, was psychosocial support. So these women actually perceived, when we spoke with them in interviews, that their coach was also a really good ear for them, somebody to talk to, with navigation and education being a little bit lower down. What did patients like about the program? This is from a recent paper from one of our postdocs, Kate Shusko, based on 94 satisfaction questionnaires and 21 qualitative interviews. So they really liked the education and tools, the resources on the websites, and on the website and some of the other tools. A lot of them talked about the importance of the supportive relationship with their coach, with regular check-ins, troubleshooting, someone in my corner, goal setting, and motivation. They liked the flexibility and the personalization of the program, that it fit into their life. And they liked the fact, a lot of them articulated that this was the first time that they were given permission to prioritize their own health. Areas for improvement: they wanted to choose which goals to focus on, not to be told they had to focus on physical activity or diet or both. Longer program duration, particularly when they returned to work. They didn't like some of the log keeping that we had done as part of the evaluation. They would have liked to have other modes of contact, like email or text, not just telephone. And they would have liked more psychosocial or peer support. And these are just a couple of quotes from some of our participants. "I learned so much in terms of making changes in my lifestyle and pushing myself to do better for me and my family. In my second pregnancy, I tested negative for gestational diabetes. Like, that was something I was really happy about. I believe one of the reasons was because of the lifestyle changes I adopted." So that to me was a really nice thing to hear, although anecdotal. That's kind of what we're hoping for. Okay, whoops, sorry. Next. And then we also spoke with the coaches. Just 5 of them were able to speak with us, but they also found it very rewarding. They found they really like to build that rapport and develop a relationship with a patient. They like the flexibility, and they like the virtual and remote program delivery. I'll tell you, during the pandemic, we were able to continue the coaching because our dietitians, most of the CDEs were mostly dietitians, were able to work from home and continue to provide this service. But there was a lot of paperwork because it was a trial. So that was one of the challenges that we're hoping in the real world wouldn't be a challenge. So to summarize what we learned in these 2 phases, and then I'll take a couple, 5 or 10 minutes just to tell you about what we're going to do next. One is I've shown you now that there's growing evidence for effective postpartum type 2 diabetes prevention programs, both from evidence before us as well as from our study. And we're still working on some of the effectiveness data that we'll share with you when the time comes. The program, though, we know is associated with high satisfaction and engagement. We showed that this type of low-touch virtual program is highly feasible for patients, providers, and healthcare systems. But we cannot abandon the relationship aspect of the program, because we found that the relationship with the health coach and the frequent follow-up was key to engaging and retaining our women. And so, getting an AI-based coaching program or having everything asynchronous through text messaging or through a website may have some benefit, but we found that you also have to supplement that with somebody real, as someone who can offer that support and develop a relationship with the patient. We also learned that we need better strategies for transition of diabetes care after delivery. We lost a lot of women in the postpartum phase. Behavioral interventions need to be flexible. They need to be individualized, and they need to consider gender-specific social and emotional support. So we actually need to think about how can we help women find the right resources for that added social and emotional support. And we need to find ways to move from research to practice, to integrate these type of programs within the standard of care. And so that takes me to the next phase of what we're doing. Sorry, why is it not letting me go forward? There we go. Okay, so phase 3, this is what we've been doing over the last almost 2 years now, or 1.5 years, I think. Yeah, 1.5 years, integrating postpartum diabetes prevention within the healthcare system. So the goals of this phase, one is we want to streamline and build on the current pathways and processes for prenatal care and postpartum care. We wanted to design a transition pathway between prenatal and postpartum care. And to do that, we needed to increase collaboration and communication between healthcare systems and organizations while improving patient experience as well as provider experience, and then ultimately with the goal of building a sustainable program to reduce type 2 diabetes in this population. And so this is what the two goals of this next phase is, one is to implement that care transition pathway in three Ontario jurisdictions: Mississauga, Toronto, and Waterloo. And then optimize our ADAPT-M program to incorporate what we've learned from the evidence and from the trial. And we've received funding, co-funding from CIHR and the Ministry of Health in Ontario to actually implement this research project, which is focused on implementation in 3 real-world settings. And so ultimately, once we've created our care transition pathway and optimized the intervention, then we're going to implement the program in these 3 sites. These are our 3 sites. The prenatal referral site in East Toronto, Michael Garron Hospital, referring to South Riverdale CHC, Mississauga Hospital, and now all of Trillium, because the mom-baby program is going to be merging, to CarePoint Health. And then in the Waterloo region, Lang's Community Center actually sees the women prenatally who have GDM, and so they're going to be also delivering the postpartum program in their CHC. This is our quadripartite leadership team. So from the beginning, this implementation grant made it a priority that no one person leads this. We have to make sure that we have representation from all the important players. 1 is researchers, 2 is providers, 3 decision makers. So we have folks from Ontario Health as well as from the 3 jurisdictions. And we have 5 patient partners. Actually, we have 4, but 1 who's now left us, but still very engaged. And then we have partners as well. We also, instead of just training our CDEs ourselves to deliver the program, we've actually given them the opportunity to undergo certified health coach training. There's a program at McMaster University, which is specifically geared towards healthcare professionals who want to learn how to do health coaching. And so there are 3 existing components of this health coaching certified program. 1 is lifestyle and wellness, 2 is chronic disease, 3 is cultural humility, and then we have added the ADAPT-M postpartum module. So anybody who undergoes this program at McMaster would get these 4 components, and they would have a certification in health coach training. And there's a QR code if anybody wants to register, or send us a note after if you're interested. We currently have 7 coaches, I believe, who are undergoing the program, and with 3 at CarePoint in Mississauga who are going to be ready to deliver the program this summer. We also undertook an ADAPT-M workshop with all of our team. As you can see here, we actually held it at UTM. We had persons with lived experience, healthcare providers, administrators, researchers, trainees, and content experts. And we basically got together and hammered out different components of the program that, you know, we thought we needed to have, would be nice to have, and what we shouldn't have. And we use those data to update our program. I'm going to thank my team very much for all the hard work in putting this together. And then during that time, during the last 1.5 years, my postdoctoral fellow, Kate Sushko, has been very busy doing a pre-implementation assessment. And so what that involves is taking using implementation science methods to understand what are the barriers and facilitators to implementing this type of program within the 3 pilot settings. And the barriers and facilitators can be across 5 different domains. The intervention itself, you know, what about the intervention is a facilitator barrier? Implementation barriers and facilitators. individual barriers and facilitators, and then barriers and facilitators at the inner and outer setting. And so she did a series of qualitative interviews with providers, administrators, and patients, as well as surveys. And I'm just going to show you briefly what she found. So, and before I'm going to tell you what she found, she also undertook a scoping review of the literature to understand what are some of the implementation barriers in the literature across those different components of implementation science. So reach, begin recruitment. So timing, very important to begin recruitment during pregnancy to get higher participation rates. Intervention delivery should have a combination of face-to-face, virtual, individual, and group settings, and tailoring the delivery approach is really important. Longer duration with frequent contact points supports better goals. And then maintenance was supported through let's see, maintenance was supported through studies that, yeah, this is just some comments on some of the data that was collected around maintenance. Okay. Okay, so what did she find around facilitators and barriers to implementation? So luckily, there were a lot of facilitators. There were a lot of things that are in our favor to implement this program. One is that people really thought that virtual care is really easy to implement. And it's good in a way we just came out of COVID because people now understand, you know, and are comfortable with virtual care. Everybody we spoke to believed in the need for this program. So they actually had buy-in that this was an important program or that we needed some sort of support for this population. So that's really important. People need to be, you know, to be behind us and need to be believe in the program. People felt there's a lot of existing e-referral networks that we could leverage to create our transition pathway. And people were everybody was very highly committed to success. And the 3 places that we've engaged with have very supportive environments. So we're really lucky there. And another piece they felt that would be a real facilitator is if we just call this standard of care and we integrate it early within the diabetes pathway. At the moment they're diagnosed with gestational diabetes, you integrate it into standard of care. But the barriers are there. So, and these are not surprising to us, and we really need to address them. This is a difficult time and busy time for women. There's no existing pathway for this population, and they differ across the 3 sites. Imagine how many sites if we want to expand this. And then who's responsible for postpartum diabetes testing? This is a big deal. You need a doctor or nurse practitioner to order the diabetes test. And it's not as easy as you think to just say, well, get the family doctor to order it, especially if women don't have a family doctor. The family doctor's not been involved in their care. So there's a lot of challenges there. So this is just the strategy that we've come up with to as our transition and implementation strategy based on all the data that we've collected. So we're building on what usually happens. So the black arrows are what usually happens. Women get pregnant, they see their OB or midwife, the OB or midwife diagnoses them with GDM, refers them to a prenatal diabetes team, and the prenatal diabetes team provides care until delivery. After delivery, there's maybe some transition between the OB and the primary care physician, but not always. And then the patient is tasked with going to see her primary care provider, but it doesn't always happen. So what we're proposing are the yellow lines. So once the woman is diagnosed with GDM, the diabetes team refers them to a health coach. A health coach gets assigned to them while they're still pregnant, contacts the patient, and does a warm handoff. They connect with the primary care provider. They continue to see them postpartum for the ADAPT-M program. Primary care provider, as always, is responsible for the other health services, but the health coach can also be responsible for community resources. So that's what we're proposing. And where are we at in the timeline? I'm almost done. So this is all the work we've done so far. We are right now in February. We're in February 2025. The health coaching training is ongoing right now at McMaster. We are just completing our trial analysis, interpretation, and preparing our manuscripts. We're finalizing our implementation plans for each of the sites. They have to be quite detailed. We're creating our patient tools and curriculum for ADAPT-M. We're just submitting our REBs, and our goal is that we start referring women during pregnancy in April of 2025 with the program to be implemented as of the summer. Because remember, women have to deliver and they have to be about 3 months postpartum. And then we will implement the program and we will evaluate it over a 2 to 3 year period. So stay tuned for next steps. So, and I didn't talk a lot about what we're evaluating, but basically we're evaluating both implementation and effectiveness metrics, and I can answer any questions about that after. So just to summarize, I hope I've convinced you that GDM is a really unique and wonderful window of opportunity to identify women who are at high risk of type 2 diabetes and help them prevent it from progressing. Early intervention is essential. We've shown you there is evidence for benefit of structured postpartum programs. Our program is associated with high feasibility, retention, and satisfaction, and we're using evidence-based strategies to ensure success. But we also need strategies to optimize reach and effectiveness, focused on a gender transformative approach, really focused on the unique needs of this population. And we need effective implementation strategies so that we can move evidence sustainably into practice. And I want to thank all my team. I'm sure I've forgotten people there. And oh, that's it. And I'm going to stop sharing. Thank you very much for your attention. I'm sorry I left only 5 minutes, but any questions?
Thank you. Thank you very much, Lorraine. What an incredible body of research, and so excited for all the milestones that are ahead for your team. In the interest of time, I'd like to open up for others on the call to ask any questions for Lorraine. Caroline, go ahead.
Oh, hi, Lorraine. Oh, that's a tremendous, fantastic work. Congratulations for you and for all the team. I have actually a comment, and one is actually because I'm dying of curiosity. I'm not going to answer what I want to ask, but so one is it's just a comment actually, because we know that in terms of lifestyle interventions in a population level, sometimes you do a tremendous work like in improving lifestyle in a whole population, and you have a huge effect in a population level, right? But when you do an analysis of a subgroup, you may not find anything. It's just like reducing salt, right? When you tell your patient in front of you, you may not see anything, but in terms of population. So that's a comment that I have, that I'm wondering, because we just analyzed our results of the EMPA trial, and I can tell you that it's very difficult to find significance when you do a subset or analysis of effectiveness. But it's my kind of impression that I think it wouldn't detract from the tremendous work and the overall change in a population. So that's actually a comment. And the second is that I think that's all you can answer now, Lorraine. But what is the effectiveness outcome? It was weight loss, because you mentioned that the dietary advice, it wasn't you're actually not advising people to do caloric restriction because they are breastfeeding, right? But it's going to be hard to find if you're not actually. No. It's already hard when you do that, right? Yeah. So my understanding is that it was more like improving the quality of diet. Yes. Like but yeah, so that's my question actually. How you guys are gonna in the trial that is being analyzed, what's the primary outcome? It is weight loss?
Very good question. So we had made our primary outcome weight because we recognize that this is a time where women would normally be losing weight. But our hypothesis was that even if the low GI diet is not intended for weight loss, it's intended, but we hypothesize that it would help women feel more satiated and therefore be more likely to lose weight. So we still felt that we could see a benefit on returning to pre-pregnancy weight, for example, but we were looking at relative difference across the arms in weight. So, but you're quite right. And to your first comment, it is very hard to see signals in a relatively small group like this one, right? So so we have to have faith, just like when we looked at the meta-analyses, one of which I will say Carolyn was one of the lead authors on, that I showed that when you combine all the data, you actually can see a signal. It's just, so I don't moving forward, I don't think weight is the best outcome, to be honest with you. I think what we're actually moving forward, because we're now doing an implementation type 3 hybrid effectiveness implementation trial, which focuses on implementation outcomes as a priority rather than effectiveness, but we're still measuring effectiveness, but our effectiveness outcomes are based on goal setting.
Right.
So not based on we're also going to look at weight. We're going to look at physiologic measures. We're going to look at whether or not they're able to reach the guideline recommended diet and physical activity outcomes that everybody should be doing. But we also want to see whether they're able to meet those goals towards the outcomes, because we feel that that's also a good measure of ultimate success.
Right. And the other thing, like as I presented the other week, a lot of these risk factors, you're going to find an impact like years later, right?
Yes.
So it may be
Yes.
that you're not going to see anything in 6 months, in 1 year, but you might see in 3, 4, right?
Exactly.
So, yeah.
I know.
Yeah, but anyways, I think that's fantastic. I think that's something I'm sure you guys are already thinking on that, right? How we're gonna measure this in 5 years from now? What's the incidence of diabetes in the population? So I think you might have like it may be fantastic. Like
Thank you, Carolyn. I really appreciate your input. That's great. And thanks for coming, by the way.
There is a question in the chat as well, Lorraine.
Sure.
Have you considered partnership with public health units to implement this program?
That would be great. So far we've partnered with Ontario Health because of the fact that we want to ensure that this program gets implemented within the healthcare system. And of course, because the Ministry of Health is actually co-funding this, we've also been in discussions with people at the ministry around how can we spread and scale this program if it's successful. But I would welcome input from public health units if they think that this could be something that could be promoted or supported by public health. Was this from if it was someone from public health? Oh, Shannon, if you're from public health, I would love to, follow up on that. You can send me an email.
Wonderful. Just any last minute questions? Otherwise, you know where to find Lorraine if you have any questions. And thank you for confirming the slides. We'll check with Lorraine, and any material that she's able to share, she'll definitely share it with you. So I know we're running out of time, and I'll just wrap up to say that please ensure that you complete today's evaluation for this session. Lydia has added the link to the chat pod, and this will be also sent to you via email. Next, please join us for our next NHP seminar on March 17, 2025, where we will have Dr. Ambreen Sayani and Elise Maybe speaking about shaping inclusive spaces for patient and caregiver voices in healthcare decision-making. Please look out for the flyer for this event and registration instructions. You can also visit our website at healthypopulationsnetwork.utoronto.ca for more information to register for this event. Thank you very much for joining us today, and we hope to see you again on March 17th.
Thanks, everyone.